All right, thank you very much. I have a lot of slides to go through, and just a quick note, Hawaii, we're hitting our third wave. We've actually run out of oxygen. The island cannot make enough oxygen for our patients. Elective surgery has been shut down for 2 weeks now. We're predicting another 4 weeks. Our governor is saying, please don't come to Hawaii. I'm saying, please come to Hawaii. I think we're okay. Here are my disclosures. And we're going to run through this as quick as we can here. So why is surgical smoke so important, and what impact does it have on us? Surgical smoke contains over 150 chemicals that are toxic actually to us. Operating in a room with smoke is like smoking 27 to 30 cigarettes a day. We need to have smoke evacuation systems in our OR to remove the smoke with capture devices, vacuum devices, and inline filtration. So using different energy sources, like an ultrasonic dissector can create large particles. Using electrosurgical instruments like monopolar energy can create very small particles. And these particles can enter your lungs and deposit in different places. So just as a quick reminder of definitions of filtration, basically, we all know what an N95 is. It filters out 95% of particles greater than 0.3 microns. HEPA filters, like in our vacuum cleaners, can filter out 99.97 particles, 3 microns in diameter, 0.3 microns in diameters. And what we use in the OR are something called ULPA filters, ULPA filters that can filter out 0.12 microns. And this is the filters you need to use in the operating room. This is a quick kind of physics demonstration of how our masks work, the masks you folks are wearing. There's 5 mechanisms: straining, inertial impact, electrostatic attraction, diffusion, random Brownian motion, and interception. And the 2 highlighted things are what we use, our masks use to kind of catch particles when we're standing in that MGM elevator with people not wearing their mask. Filtration in the operating room, very important. Once again, it's a multifaceted approach. You want proper room filtration and ventilation, appropriate PPE, smoke evacuation devices with suction and filtrations on them. So, the whole theory about after intubation, you should wait 5 minutes before you enter the room on a COVID-positive patient is based on this study. Basically, most ORs are positive pressure. They're not negative pressure. It's very difficult to find a negative pressure operating room. They're not designed in that way. So basically, every 4 minutes, the room recycles 100% of the air in there. So on average, there's 15 air changes every hour. So at 5 minutes, if using electrosurgical units, the concentration of particles can raise from 60,000 to 1 million. After 20 minutes, that filtration system can get all that particles out of the room. These are different mechanisms we use in the OR. We want your suction filters have a 3-filter system: pre-filter, ULPA, and charcoal. Inline ULPA filters for your wall suctions. Your smoke evacuators we use now have ULPA filters, and the capture devices on our electrosurgical pencils have ULPA filters on them. This is a very important triangle to remember. So elimination, substitution, engineering controls, administrative controls, and PPE. So basically, the most important thing is eliminating the risk, the smoke and the virus particles in our OR by filtration. Substitution, changing clean air from contaminated air with positive and negative pressure. Engineering controls, only have people that need to be in the OR, and basically educating your OR staff about mitigation techniques. And everybody in the OR in Hawaii, we're mandated to wear actually N95s in their OR 100% of the time with eye protection now. So a good thing to know is this thing called protection factor. So the N95 masks you wear that are OSHA have a protection factor of 10. That means when you're in that elevator, if there's 100 particles in the air, there's going to be 10 that you're going to breathe in. So if there's 10 particles in the air, you're going to breathe in 1. So the higher the number, the better. Right now, I have a protection factor of 1. So 1 particle out there, 1 particle in my nose. Your mask, the cloth mask you wear, have a very low protection factor. So we need to know that and I'll talk about the coronavirus is a very small particle, and it can go through the mask. So, but we know that N95 respirators provide at least 8 to 12 times better protection than a surgical mask. So wear your N95s when you're in the operating room. And this is a typical box manufacturer. It tells you the signed protection factor of 10 and the type of filtration mechanisms that are involved in it. So very briefly, we all know about this. SARS-CoV-2 is found in all kinds of secretions. We know the Delta variant has 1,000 times more viral particles. That's the problem. In Hawaii, it's all Delta virus. We have an 80% vaccination rate, but during the first shutdown, we had about 200 people infected a day. Now we have 1,200 people infected a day. Our ICUs are full. We have no capacity anymore in Hawaii. These are the viruses and their sizes. We know that HPV and hepatitis have been found in surgical smoke. This is the first study ever in the world. It just came out last week. 17 patients underwent laparoscopic procedures for gynecology malignancies. All were COVID negative. It's very difficult to do an RB study on COVID positive patients now. In this study, they isolated 1 patient with aerosolization in the filter of the exhaling vent from the laparoscopic port and the ET tube. So this proves that the COVID virus can be aerosolized. This is the only study, and just came out in the world. Imagine if these patients were all COVID positive. This was a false negative that went to the OR and became a true positive. So this is a documented evidence that we can have COVID virus escaping into the air, which is okay, because when we treat COVID patients, there is millions of COVID particles flying in the air, but we have our N95 on, we have our eye protection on, we're protecting ourselves, and we don't get infected. So in the OR, I believe coronavirus can escape out, but as long as you're wearing your protective equipment, you're safe. We know that some other viruses, like norovirus, only takes 18 viral particles to get you infected. Influenza, 10. We're not sure about COVID, but it's a pretty low number. Okay, so very quickly, surgical smoke. Basically, you need to evacuate the smoke out of the OR. We know that viruses can be transported in smoke. Options considering open surgery, basically, you should use the suction devices attached to the pencil. If you're using just your Yang Carver sucker, make sure that thing is at least 2 inches by the surgical smoke to get everything out. In laparoscopic surgery, make your incision small. Alpha filter should be used. Pneumoperitoneum pressure kept at the lowest possible. Suction your CO2 smoke out. If you're using electrosurgery, set it at the lowest setting possible. And during desufflation on a COVID positive patient, make sure you get that gas all the way down through your ports into an ALPA filter, and don't let it actually escape into the room. Also, all members in the OR, especially in COVID positive patients, should wear N95 masks. Converting to open surgery from laparoscopic, get that CO2 out first. Specimens should be removed once all the CO2 gas and filter is filtered out. Be careful of suture closure devices, and hand-assisted surgery can lead to leaks and everything. This is our SAGES kind of poster. If you don't have this, you should print it out, get it in your ORs. This is how you get the message out. So in conclusion, you need to protect yourself and your OR team from the dangers of smoke. Adjust your surgical techniques to reduce your exposure, and basically look at all the filtering mechanisms in your operating room. Thank you very much.